Thank you for joining us for this MD Magazine peer exchange on multidisciplinary perspectives on reducing cardiometabolic risk. That's a mouthful for you. The relationship between type 2 diabetes mellitus and cardiovascular disease is, at the very least, complex. Fortunately, many of the risk factors are modifiable and effective therapies are available. And I'm pleased to be joined today by a multidisciplinary panel of experts to review the current diabetes treatment landscape in the context of the latest cardiovascular outcomes trials. We will also discuss the importance of treating the whole patient to reduce overall risk. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University College of Physicians and Surgeons and associate director of surgical intensive care at New York Presbyterian Hospital. Joining me for this discussion is Dr. Stephen Brunton, adjunct clinical professor in the Department of Pharmacy Practice at Rosemarie University of Health Sciences in Salt Lake City, Utah, and executive director for the Primary Care Metabolic Group in Los Angeles, California. Dr. Rosemarie Lajara, adjunct professor at University of Texas and professor of medicine and endocrinology and diabetes of America in Dallas, Texas. Dr. Christian Ruff of the TIMI Study Group, part of the cardiovascular division at Brigham and Women's Hospital, Harvard Medical School in Boston, Massachusetts. And Dr. Karol Watson, professor of medicine and cardiology, co-director of the UCLA program in preventive cardiology, and director of the UCLA Barbara Streisand Women's Heart Health Program in Los Angeles, California. Thank you all for being with me today. So why don't we get right to work? We mentioned the whole patient here. I mean, doesn't everybody treat the whole patient? And if not, why not? And if so, how does that relate to metabolic risk anyway?
Well, you know, the whole patient is such an interesting thing. Diabetes is the patient's problem. And we, in a sense, tend to segment the patient in terms of cardiometabolic risk or whatever else. And really, because it's the patient that manages diabetes, we need to understand what their priorities are, as well as kind of mixing them with ours. And so it's not just the issue of treating diabetes, but it's treating, as you say, the whole person. Part of our problem has been that we have been so glucocentric that we haven't really looked at some of the other risk factors. And frankly, it's lipids and hypertension that may be even a greater risk for the patient.
But you know, I was always taught back in the days when dinosaurs roamed the earth that you take care of the sugar, the metabolic syndrome, the vascular disease, the ocular disease, all that's going to take care of itself. Not true, guys?
Not true.
Oh, I feel so misinformed. Why so?
All the interventions that have been geared to control glycemia have proven to not really have an impact. However, blood pressure and lipid management does translate into better outcomes.
So we're talking about cardiovascular-related morbidity and mortality here, right?
Correct.
I mean, you're not really saying ignore the sugar. You didn't say it didn't have an impact, did you?
No.
I thought I heard you say
No, I didn't. I didn't.
No, and I think we know, I mean, there's longstanding evidence that hyperglycemia is bad for both microvascular and macrovascular complications. But importantly, weight loss and certainly controlling blood pressure and lipids are very important to modify the risk of the end-stage complications of diabetes, but also what many diabetic patients ultimately die from, which is cardiovascular disease.
But what about that is unique to diabetes? In other words, I take somebody with an A1C of 5, let's say, and a fasting blood glucose, which nobody does anymore apparently, and it's normal, and that person's overweight, hypertensive, has a bad metabolic profile, lipids off scale. You're going to still tell them to do the same stuff, right? You're still going to tell them lose weight, exercise, control your blood pressure, control your lipids, whether or not they've got diabetes, right?
Well, that's exactly right. We're never going to stop recommending lifestyle, at least we shouldn't. But what's important to remember is that if a patient comes to you, they've heard the message, I have diabetes, I've got to control the sugar. They are really focused on that. It's our job to educate them about the whole patient themselves, how that, yes, we will control your glucose, but we're going to make sure you control your cholesterol, control your blood pressure, lose some weight, move every day, eat properly.
That's part of the problem. We're asking people to change 25 different things about their lifestyle. And I think when I see physicians can't change their lifestyle risks, more than 1 or 2 at a time, and yet with diabetes, once you get that diagnosis, it implies that everything is over. So it's really kind of, once again, working with the patient's priorities. I think that we recognize as you said, Peter, that all of these things are important, but you can't do it all at once. You need to work really on a gradient with patients.
And I think it's also not one physician who can manage this all in the confines of busy clinical practice, especially this day and age where you have 20 minutes to see a patient. But I think now we're realizing for diabetic patients like other patients, managing the primary care, endocrinology, cardiologist, where everybody can focus potentially on different areas, because this patient's not going to be able to get all of their, risk factor modification and treatment of their diabetes all within the confines of one
I would love to
physician.
explore the 20 minutes that a doctor seems to have with this patient where you
A whole
live.
other.
But I don't think most doctors even have that. But is it fair to say that, yes, all these things are important, whether it's lipid, hypertensive, weight, exercise, but in the setting of an A1C that's elevated, they become that much more important because there's a pre-existing risk that other people don't have. Is that fair?
I think so. One of the variables that determine cardiovascular risk is duration of diabetes, that high A1Cs, among other things. So we have to prioritize. It doesn't mean that we're not approaching the patient from a global risk reduction perspective, but you set your priorities depending on what you think is the most relevant.
Well, what have we learned then about this link? We seem to know, there's a link between diabetes, metabolic syndrome, cardiovascular related morbidity and mortality. Where's the link?
No, I think you're very right to highlight the stakes are even higher in patients who have diabetes with respect to cardiovascular disease. We know that if you take diabetics, they have a much heavier atherosclerotic burden, and they often have very abnormal sort of plaque phenotypes in the artery, so they're more likely to be unstable and rupture. And we know that even the modifications that we have to aggressively treat cardiovascular disease, they don't seem to be as modifiable as other patients. So cardiovascular disease is a big problem, but it's an even bigger problem in diabetics because they seem to have a more malignant type of cardiovascular disease.
And I think what you were asking is, what is the underlying
why?
pathophysiology
Why?
that holds it all together? And we don't know exactly why, but we do think insulin resistance underlies a lot of it. And the problem with insulin resistance is that it's absolutely invisible for a lot of years.
Okay.
So by the time a patient is actually diagnosed with type 2 diabetes, they've probably had 10, 15, maybe even longer years of insulin resistance, which means higher insulin levels, vascular toxin, and they're set up for disease.
So did I just hear you say that insulin is a vascular toxin?
Well, so
I wasn't listening.
insulin resistance
Insulin
is a
resistance.
vascular toxicity.
And
It's a
actually,
risk
it's
factor.
considered an independent risk factor.
It is.
Yes.
And also having diabetes is a pro-inflammatory state too. So you have a worsening situation with increased sort of endothelial problems as well. And I think that may be, there's so many different sort of hypotheses and physiological explanations, but there's no question that people with diabetes really are in a vasculopathic state.
I think it's worth noting that the more we learn about cardiovascular disease and ischemic heart disease, it's an inflammatory problem. And if diabetes is a pro-inflammatory state, that sort of does make sense, right? But I can't tell you how thrilling it is to hear you say on camera, we don't know. Because after all these years of studying diabetes, we still really, on a very fundamental level, we don't know.
This is true.